In this video, we will discuss about clinical application of the knowledge you've gathered in past 3 lectures about occlusion. So before we discuss about that, let's ask us another question: why application of occlusion in clinical dentistry is relevant. So if you look at this pie chart, it's a very simple pie chart which shows that the blue section comprises of the simple cases which doesn't need occlusal intervention. And in my case, in my opinion, more cases needs occlusal intervention than we initially think. And the more and more occlusal knowledge you will have, you will be able to apply that knowledge into your day-to-day practice. However, let's consider that this blue part of the pie chart represents a true simple cases. You have this orange space now where the cases are ever so slightly moderately difficult, and making the jump from blue to orange is the reason I'm doing this course. So I would like general dental practitioners to increase their ability to treat the cases which are moderately difficult, and with knowledge of occlusion, these cases can be treated as simple as you treat your normal cases. Once you reach and once you gathered enough cases in orange section, then you can move forward to the gray section where there is severely complex cases. However, the majority of the cases fall into moderately difficult cases which can be easily treated by applying simple occlusal principles. So let's look at this case. This patient came to me with a chipped incisor ledge on upper right central. Now, on the face of it, it looks very simple. However, what we need to understand is we need to see how the guidance is playing a role when we are treating these kind of cases with the incisal chipping. So not only you need to ask patient to protrude their jaw forward and check whether there is an anterior guidance guiding in that area, you need to ask patient to move their jaw in every single direction and try and touch that area. Because one thing you need to understand is when patient is parafunctioning, they do not move their jaw forward nicely like we ask patient in clinical practice. They move their jaw in every single direction. So you need to make that understand and assess that to be able to predictably treat this case. If the same patient wants a veneer on upper right tooth, I hope not, because orthodontic treatment would solve the issue. But if the same patient wants a veneer on upper right tooth or a restoration, then you need to really think carefully, because currently the lower lateral is guiding with the upper lateral. And if patient moves on the left, or patient's left, it could be that the canine is also having an impact on that. So you need to really assess these cases carefully before you plan restorative treatment. Let's look at this case where this patient was referred to me for broken upper left tooth, and the dentist previously tried restoring that 4 times along with upper centrals and failed because the tooth keep breaking, and patient got frustrated and came to see me. Now, what are the issues you see here? There are few things I can see. That possibly when patient's guiding on the left, you can see that there is no canine guidance, and probably the patient was guiding on the lateral and the premolar. And surprisingly, you can see on the lower premolars there are some cervical abrasion which is not present on the right premolar. It doesn't to say that occlusion is the cause for that, but you wonder why this is the case. In this case, we will discuss later how to treat this patient. Or if you come across this patient was referred to me for a simple treatment of upper centrals. And however, if you look at the case, you can see that there is a generalized wear, which is not severe. It's mild to moderate generalized tooth wear, and in her case it was mainly erosive tooth wear. But if you want to treat this case, you can treat it very easily adhesive dentistry, using adhesive dentistry, but you do need knowledge of occlusion. And as I say to all my students, that full mouth reconstruction is basically treating every single tooth with the crowns or adhesive dentistry, but doing it together. There is nothing else to it. The only difference is occlusion and how you manage the steps. But if you can do a really good single adhesive dentistry with a single tooth, you can easily learn how to do full mouth reconstruction with learning few principles. Or if you see this patient where there is severe wear. Now at the face of it, it looks really complex. However, once you know how the full mouth reconstruction works and how the steps works, you will be able to you will be able to treat this patient very predictably. And this is the goal, to provide you a first stepping stone into applying the knowledge of occlusion in clinical practice, not to scare you, but to motivate you in trying to do slightly more challenging cases than what you are already used to do. So let's look at some of the application of knowledge of occlusion. So one of the application of the occlusion is during treatment planning. And treatment planning is the key if you want to do any dentistry. Even the simple dentistry involves a good treatment planning, because with the good treatment planning, you will be able to assess issues before it becomes an issue. So, but if you have a good understanding of occlusion, it helps you in diagnosing issues related to the failure, such as the case we just saw with the lateral incisor. It also helps you in how to assess mounted model. It helps you in assessing first point of contact, which we discussed previously, can become important if you want to treat that tooth or if you want to assess the slide. It helps you identifying some of the occlusal issues which can go unnoticed if you're not doing proper occlusal assessment. It also helps you in planning long-term stability, because again, you may have a knowledge of how to do full mouth restoration, but study shows that the patients don't tend to stop bruxing or parafunctioning. It tends to go in waves, and it can go worse and less worse. So you need to make sure that you have a knowledge of occlusion, which helps you in making your restoration as stable as possible for future forces to come. And of course, last but not least, it helps you planning for failure, and it helps you in planning for full mouth reconstruction cases. With regards to general dentistry, if you're using conformative approach, then it will give you more predictability when you're doing restoration. So when you're doing restoration, if you check the occlusion really well beforehand and afterwards, then you can be sure that you will be able to increase the predictability, and by doing that, you'll be able to decrease the appointment time and appointment visits. You also reduce the risk of failure due to fracture, hypersensitivity, pain, and early wear due to issues related to occlusion. You will be able to treat broken down teeth much more predictably. As we discussed in first lecture, that the fractured molar, where the palatal cusp was fractured, you can see that there was a wear facets on the rest of the tooth, and you can tell that that tooth is coming under heavy occlusal load, and how to manage that load by providing appropriate guidance, reducing or removing the non-working side interferences. You'll be able to treat those cases much more predictably. When you're doing multiple restoration without changing occlusal vertical dimension, it will help you in managing the cases with the multiple restoration but using conformative dentistry. And that's why I feel that knowledge of occlusion is much more important to general dental practitioners than the people who would like to do full mouth reconstruction. And I don't want you to get me wrong that it's not for people who want to, do more complex cases. However, you shouldn't underestimate the role of knowing occlusion in your general clinical practice. Now, when it comes to advanced dentistry, yes, when you use reorganized approach for increasing or decreasing vertical dimension of occlusion, you can also use this knowledge in conjunction with multidisciplinary approach with orthodontics and implantology, and that helps you in doing more comprehensive cases. So let's talk about treatment planning and how knowledge of occlusion can help you in assessing and in treating patients. Now, we discussed this case already where patient came to you for broken upper left tooth. In this case, you can easily treat by building canine guidance, giving patients slightly steeper guidance so the upper left tooth is not coming in a way of guidance, and that will salvage that tooth, or you will be able to save that tooth. However, the restorability of that tooth is questionable, so probably in this case tooth might have to come out. But in future cases, if you see this and if you see weakened upper left tooth which is now guiding because there is no canine guidance on that side, you will be able to use your knowledge of occlusion, and we will discuss this case in detail in coming slides. The application of assessing models can help you in assessing the wear pattern and doing diagnostic wax-up. And once you have done diagnostic wax-up, it will help you in implementing that wax-up into patient's mouth when you're doing your direct or indirect veneers or restorations. And this is the key. Mounting models and doing diagnostic wax-up helps you in overcoming so many issues, and it reduces the stress, because when you are assessing models, you are not wasting patients' time, patients not sitting there, and you don't have time pressure. You can just take your time to assess the model as nicely as possible and come across all the issues you can have and try and overcome at that same time. The knowledge of occlusion also helps you in identifying first point of contact. And as you know, and as you've seen in clinical examination section, that once you know how to assess first point of contact, and in this case, if it's a upper left 7, which is buccal cusp in this case, you can warn patient because the tooth is already heavily filled. You can see a palatal micro crack line there. Buccally as well, there was a micro crack line. And you can warn patient regarding the issues which patient can come across in future. The other help occlusion can give you is when you are identifying, when you're doing an occlusal assessment, you can identify occlusal issues. Now this case, if it comes to you and for lower left 7, missing onlay, and just look at the photo and you can tell that, okay, we have enough tooth. It's not a very difficult case to do. However, when you ask patient to bite, the patient's closes like this. Now you need to have the knowledge of occlusion as to how you're going to treat it properly, because yes, you can reduce the 7 much more further and fit an onlay there. However, the fact that there is a supra eruption of the 6 on the upper arch does not help, and you will have a very curved or steep curve of Spee. So again, this case we will discuss in later slides. If you look at this case where patient comes to you for normal checkup and you look at the smile and you look at the anterior teeth, they're really nice and untouched apart from the crowding. However, you look at the lower arch and you can see severe wear on the posteriors. Now if I go back, now if you can see here, you cannot restore the posterior teeth because there is no space, but you know that they are heavily sort of severely damaged and they need restoration. So how would you manage this case? In this case, I managed by combination of orthodontic treatment and restorative treatment, because patient I thought would benefit from reducing the crowding on the lower and improving the crossbite, not for occlusal reasons, but because patient was having braces. And when we planned, we decided, and if we improve the crossbite, I will end up with more space at the back for me to do restorative treatment without drilling patient's teeth. This can become a little bit long-term case. However, at the end, the results are much more satisfying than just putting small amount of layer or fissure sealant on the facetings, because they will come out. And this patient was 32 when I saw him, and we need to do something long-term. Or this case, when patient comes to you where patient wants the teeth replaced and broken down and worn down teeth to be restored, you need to be able to assess their occlusion and see how you're going to manage this, where one of the tooth on the upper left side is almost touching the lower ridge. Now again, we will discuss the similar case in later lecture, but knowledge of occlusion becomes much more crucial in treating these cases. This case we discussed in our first lecture, and in fact this tooth I did assess, and it did have premature contact. It had a first point of contact and it had non-working side contact, and I feel that that was the reason, along with the fact that it had an amalgam. The tooth had a vertical fracture. Now when you know how to identify these cases, you will be able to predict the failure. Now if patient does not want to have that treated, at least you will be able to warn the patient, and if this happens, you will gain much more sympathy from patient, and you will gain much more trust from patient. So in future, when you recommend something, patient will be able to listen to you more carefully. And one of the important aspects of knowing occlusion is making sure you plan for long-term stability, by which I mean that once you've done full mouth reconstruction, you will be able to restore patient's teeth with either Michigan splint, or restore patient's teeth in such a way that the occlusion is so much harmony that parafunction doesn't harm the teeth. I tend to give all my patients who had full mouth reconstructions done Michigan splint, and again we will discuss about this in detail during this course. However, this is one of the key aspects of knowing occlusion. It also helps you in treating this upper right 7, which had a secondary caries underneath the crown. Now, at the face of it, it looks pretty simple case. You have a gold crown, you have a caries under the crown, remove the crown, remove the caries, and new crown. However, if you look at carefully, on the distal aspect of this gold crown, there is a contact point, and that is the first point of contact. Now there are two things you need to understand. Once I remove that crown, as we discussed before, the patient will close more further. So A, you will reduce the vertical dimension, and hence you need to think about treating these cases and how to treat them when you're changing the new crown. But also the contact now, after I've assessed on the model, was going on the 4, and 4 is heavily filled with the mesial crack line on it, and that is also not safe. So you need to make patient understand that this is the case, and the patient would need treatment of both teeth, and then you need to be able to plan how to treat this case. Again, we'll discuss about this type of treatment in detail in the next section. Of course, knowledge of occlusion helps you in treating comprehensive cases where you need a full mouth reconstruction. So you can look at this case and you can treat this case predictably by applying reorganized principles. And this leads to a very natural progression as to knowing what is conformative approach and what is reorganized approach. So many times when we are treating multiple surfaces, multiple teeth at the same time, we need to make a decision whether we want to change patient's existing occlusal scheme. And if you are not changing patient's existing scheme and you are treating patient's teeth in the same occlusal scheme, the way that they fit, and you make them the new restoration fit the way the previous teeth or restoration fitted, then that's called conformative approach. However, if you are changing that into a new design or new scheme by maybe eliminating CO to MIP slide and making them coincide, then you are doing a reorganized approach. And in some cases, you may be treating one tooth, but it could be a reorganized approach, such as the case where we discussed the gold crown, where the crown has a first point of contact. Now, as soon as you take that crown off, if you're not replicating that same contact, same height, you are reorganizing patient's dentition, because now the first point of contact, which is CO, will go into another tooth, and you need to carefully assess that. So what are the indications for doing conformative approach? So if you're doing a single unit crown, you don't need to change patient's existing occlusion. If the patient is symptom free and the tooth you're treating is bounded by a good teeth and a stable occlusion, and patient's got good stops in MIP or ICP, then you can do conformative approach. If patient has a large horizontal vertical slide, so as we discussed before, if patient slides forward a lot and slightly vertical, that means if you remove that slide, patient will stop sliding forward into ICP or MIP, and patient may lose the anterior guidance because the jaw is going backwards, and patient may develop anterior open bite. And to prevent that, you may want to replicate the context what patient had rather than reorganizing the jaw and lose the anterior guidance, which is protrusive guidance. If patient has a previous TMJ problems, then that suggests to me that patient has lack of adaptability. And when patient has less adaptability, try and avoid doing more complex treatment. Maybe start with simple treatment and then assess before you move on to the complex treatment. We will discuss this in TMD part of the module. However, one of the key reasons when patient comes with the temporomandibular joint problems or muscle problems is because the adaptability of patient is less. And I cannot stress enough that that is one of the key area you need to really understand, and you need to be able to assess patient, how is the adaptability of this patient. And that's why sometimes before I do full mouth reconstruction, I give patient Michigan splint at my planned increased OBD to tell them to see whether they're compliant and they're using the plans which I'm giving them, and B, whether they're getting any pain or problem. So you need to make sure that you assess them properly before you go into, and if you can do conformative approach, use conformative approach. If you're doing re-restoration of anterior, let's say you're replacing anterior crowns 3 to 3, and patient's happy with the current occlusion, you don't really need to change the guidance and everything, just you can copy them. unless it's much worse than you expect. So when patients replacing existing restoration and patients happy with it, and there is no issue with the existing restoration apart from maybe aesthetic or caries or something, there is no occlusal issues, you can keep them as it is. So what are the advantages of going conformative approach? So one of the advantages we discuss is that there is no adaptation, changes to patient, and that's why patient feels much more comfortable, because their neuromusculature don't have to adapt too much. And that's why this is very helpful in patient who struggles with adaptability. This also confined to the restored teeth. So, you're not moving around in too many different areas, changing the scheme, and that's why patient feels much more easy and it's easy to do. You can use index technique, which means, let's say if you are restoring upper right 6 and you like the shape and form of that tooth, you can take an index of that tooth or a study model, and you can replicate, or a scan, and you can replicate that into existing dentition, because you are conforming, you are replicating what patients already has. If small number of restorations done, then lab process, laboratory process is made easy. You can finish the cases in single go. So if patient needs, let's say, crowns from upper right 5-6, upper left 5-6, but the 7s are there, anterior teeth are there, you can fit all those crowns in a single appointment. You don't need to break the appointments down. Of course, I would recommend that you mount the case and assess the occlusion beforehand, but you can do in much more quicker way than doing reorganized approach. So if the conformative approach is so predictable and easy, why we need to use reorganized approach? Why we want to change the scheme of existing scheme of the patient? So one of the reasons you may want to do that is because you have extensive restorations in presence of large vertical slides. So if patient's sliding vertically, very large slide, you don't want to put a restoration in the same slide, because although patient might be able to cope with that slide and the teeth might seem to be able to cope with that slide, you don't want your restoration to break because of that slide. Because now you're putting something new in patient's mouth, you would probably don't want to create the same slide in your restorations, because there is a possibility that your restoration may not be able to take it and break. If you're doing sextant or quadrant restoration with large vertical slide, similar to the previous example, if you're doing extensive restoration with large horizontal slide, but you can maintain the anterior guidance. So if the slide is much larger going horizontally, but you can maintain the anterior guidance by doing a new restoration, then you can use reorganized approach. Or as we discussed before, if the tooth which has a CO, which is the first point of contact, and that needs change of restoration, and that's the indication of doing reorganized approach. Even if you don't want to do reorganized approach, by merely taking that crown out and preparing that tooth for a new crown would cause the dentition to reorganize by itself. So what are the advantages of reorganized approach? So when you're using that approach, you are eliminating deflective contacts, which is already present in patient's mouth. You also have ability to eliminate any iatrogenic deflective contacts, which you may create by doing conformative. Would have created by doing conformative approach. You also have a better control over interocclusal contact, and you have preparation of teeth does not result in change of jaw relationship. So when you are preparing the teeth, such as first point of contact, you are trying to avoid changing the jaw relationship along with that. And it's much more controlled when you're doing that. At the end of the day, you get a stable occlusion which is in harmony with the border movement or patient's jaw movement, and because of that, you get a greater control. So by now you might be thinking, when should I use conformative approach and when should I use reorganized approach? So let's look at some of the factors which affects this decision making. So one of the factors we discussed already is type of CO to MIP slide. So if the slide is very large horizontal, by eliminating that slide, if we end up creating anterior open bite, then I would prefer to stick with conformative approach if I can. If you have a difficulty in eliminating this slide for whatever reason, because the tooth is super erupted, you don't want to extract the tooth, and you want to make sure that you keep that tooth because it's one of the important tooth in patient's mouth, then you may want to think about looking at conformative approach. The age of the patient is a controversial one. I've treated older patients with reorganized approach and I've treated younger patients with conformative approach. However, if patient's medical conditions does not allow and patients is frail and very old, then you may want to stick with conformative approach rather than reorganized approach, because sometimes it can make things complicated. If patient has a history of parafunctional activities, then whatever approach you're using, you need to think how you're going to protect those restoration, because patients are not going to stop bruxing. So if you're doing reorganized approach in a heavily brux patient, you need to be able to choose appropriate restoration which can cope with occlusal load, and also you need to protect them by giving patients some sort of occlusal splint therapy in order to make sure that your restoration lasts and can take the forces which parafunctional habit produces. The other factor is the number of occlusal surfaces you're going to treat. So if there are, after 28 teeth, if you're treating 27 teeth with the crowns, you have to consider reorganized approach, because once you prepared all the crowns, you will lose patients the current occlusion. Even if you're not doing all of them together, if you're doing section by section, you're doing few crowns at a time, I see a great opportunity if you're doing reorganized approach to restore patient's mouth with much more control than doing 2 crowns at a time and replicating, which may be the reason why patient destroyed all those 27 teeth. So think about reorganized approach when you are treating multiple teeth or multiple occlusal surfaces. If you have an unstable posterior occlusion, then you need to think about doing reorganized approach. If you have a stable posterior occlusion and you're restoring anterior teeth, there is no need to reorganize approach. However, make sure that you check patient's slide, because in some cases, especially when patient has a large horizontal slide, when patient slide forward is such forceful that patient will hit the upper anterior teeth with the lower anterior teeth and can destabilize your restoration. So just keep that in mind when you're treating anterior teeth and assess the slide of the patient. But as I said, large horizontal slides are not that common, and that's why we are, getting away with it. The other issue is mandibular dysfunction, and that's something you need to treat first. And when I say mandibular dysfunction, it's actually a wrong term. If you have a dysfunctional jaw where the TMJ is painful, the muscles tender, I would try and keep treatment to simple until you eliminate those issues before you try and do reorganized approach. So I hope this is helpful. In this lecture, you learn why application of occlusion in clinical dentistry is important and how it can be used during treatment planning. In the next video, we will discuss about routine dentistry and how to use your knowledge of occlusion when treating patients while doing general dental practice.